Good afternoon, everybody. I'm Chris Fournier, and I'll be talking today about calcium channel blocker and beta blocker overdose, overview, and treatment. The things we'll be discussing today are pharmacology, pathophys, clinical features, physical exam, treatment, and transport decision making. So, first off, pharmacology. We have calcium channel blockers. These work to block voltage sensitive calcium channels such as CAV1 and work specifically on L type channels. Cav1 can be broken down into four subsections: Cav 1.1, 1.2, 1.3, and 1.4. The L channels can be broken down into three chemical subclasses of phenylalkylamines, dihydropyridines, and benzodiazepines. Phenylalkylamines work mainly on the heart, while dihydropyridines work mainly on smooth muscle. So what does this cause? This is a slowing conduction through the SA and AV node, and therefore causing a partial AV block which slows the heart rate. The slowing of the heart rate, as well as a decreased force of contraction of relaxation of smooth muscle. They are also classified as a class 4 antiarrhythmic as per the von Williams classification. Beta blockers. Beta blockers work obviously on beta receptors. Beta receptors can be broken down to three categories of B1, B2, and B3. B1 cells are found predominantly in the heart, kidneys, and in fat cells. Stimulation of B1 causes increased SA-AV and ventricular muscular firing, which then results in an increased heart rate and contractility, which causes increased cardiac output. B1 cells are also found in kidney smooth muscles in the juxtaglomerular apparatus. Now, these contract and release renin. Through the renin-angiotensin-aldosterone system, this causes an increase in blood volume. Beta 1 also causes an increase in lipolysis. Beta 2 receptors are predominantly present in airway smooth muscles, but are also found in cardiac muscles, uterine muscles, alveolar type 2 cells, mast cells, mucus glands, vascular endothelium, and skeletal muscle. They also are responsible for releasing glucose from the liver. Now, beta blockers can be selective or non selective, which means they target specifically one beta receptor or multiple. So, verapamil, which is a calcium channel blocker. Verapamil is often prescribed for patients who are suffering from angina, hypertension, and those for prophylactic reasons who have suffered an MI recently. So it belongs to the class of phenylalkylamine derivative selective calcium channel blockers. It comes in 80 milligram immediate release tablets, which is a max dose of 480 milligrams daily. They also come in 120 milligram sustained release tablets. Plays into the overdose signs and symptoms later on in the presentation. Has a half-life of 2 to 8 hours initially and 4.5 to 12 after repeated oral doses, and absorbed through the GI tract and excreted through urine and feces. So verapamil blocked the opening of activated and inactivated myocardial L-type 2 channels. So are more marked, effects are marked in tissues that fire frequently, are less completely polarized at rest, and whose activation depends exclusively on the calcium current, such as SA and AV nodes. So this slows that pacemaker activity and decreases AV nodal conduction. Propranolol is a beta blocker, is often prescribed for patients suffering from anxiety, migraines, hypertrophic cardiomyopathy, essential tremors, hypertension, angina, and cardiac arrhythmias. It is a non-selective beta 1 and beta 2 antagonist. It comes packaged as 10 milligrams up to 40 milligrams, regular release tablets, or 80 milligrams extended release. Again, that plays into the overdose signs and symptoms we're going to talk about later. Its onset's 1 to 2 hours and has a half-life of 3 to 6 hours. It's widely distributed. It does cross the blood-brain barrier and the placenta. This can show up as delirium and seizures in our overdose patients that we'll talk about later. It's excreted mainly through urine, is absorbed mainly through the gastrointestinal tract. Its duration is approximately 6 to 12 hours in the immediate release and 24 to 27 hours in the extended release. Pathophysiology. So here's the cardiac action potential. We're not going to get into it at a great length, but we want to know what the drugs verapamil and propranolol affect on this cardiac action potential. So the cardiac action potential consists of 4 phases, 0 through 4. Technically 5, as 4 repeats itself. Phase 0 is your membrane potential increasing from negative 90 millivolts to negative 70 millivolts and sodium channels opening. Phase 1 consists of the sodium channels closing and fast voltage gated potassium channels transiently opening. Phase 2, this is where the calcium channel blockers work, verapamil specifically, and L-type calcium 2 channels open, your fast gated potassium channels close, and your slow delayed rectifier potassium channels open in phase 2. In phase 3, we have your L-type calcium channels closing, your fast delayed rectifier potassium channels opening, and your potassium channels reopening. Not the delayed rectifiers, but just the regular potassium channels. And then phase 4 is your resting membrane potential at 90 millivolts. So beta blockers affect phase 4 of the cardiac action potential. They do this by blocking the effects of catecholamines at the beta 1 adrenergic receptors. This causes a decrease in sympathetic activity of the heart, reduces intracellular cyclic AMP levels, and reduces calcium influx. This causes a decreased conduction to the AV node. Now, calcium channel blockers work on the phase 2, the plateau phase here, the phase 2 of the cardiac action potential, and this also decreases conduction through the AV node. Also, propranolol has some mild sodium blocking channel blocking inhibitors as well, so it will actually cause a widening of the QRS complex and affect phase 0. Now that we've talked about pathophysiology, we're going to be talking about clinical features. So, what does the patient look like? Well, depending on the stage of the overdose, the symptoms could be varying. Also, if the patient took a long or immediate release or a sustained release, that could affect how fast the sign and symptoms appear. And paramedics should have a high index of suspicion the patient's condition may worsen depending on the severity and the amount that they took. Also, if the patient's vomited at all and taken anything else with the propranolol or the verapamil to make the attempt more successful, such as grapefruit juice, alcohol, anything that could be adding to the effectiveness of the medications. So, some of the clinical features that you're going to see with your patient are headache, fatigue, and dizziness. Bradycardia, as we've talked about, the slowing of the SA and AV node, constipation, worsening bronchospasms and shortness of breath with the propranolol and the beta 2 blockade. And this is should have a high index of suspicion and of patients being very sick if they have an underlying history of asthma. Hypotension, hypoglycemia, flushed skin due to the smooth muscle dilation of verapamil. Again, propranolol can cross the blood-brain barrier, so you're going to have signs and symptoms of seizures, delirium, widening QRS due to the sodium inhibition of propranolol as well. And then, depending on the type of treatment that the hospital chooses, you could have hyperglycemia with glucagon administration, and you want to be treating that accordingly. So, the physical exam, what are we looking for and what are we looking at? So, what we want to start with your ABCs, your airway. Is it patent? Is it protected? Do you need to suction it due to vomitus or secretions? Do you need to put an airway adjunct in there at this time? Their breathing. Are there clear lung sounds, or do we have bronchospasms due to the beta 2 receptors being blocked? Again, this is really bad for patients if they have the history of asthma. Or do we have fluid backup now due to decreased contractility of the heart, and we're exacerbating a comorbidity of heart failure that's already there? Do we have a strong regular pulse or a weak irregular one? Are they maintaining a mean arterial pressure to perfuse vital organs? As per Ho et al. And his team, the primary objective of treatment is to establish hemodynamic stability in a verapamil and propranolol overdose. So then for the vitals, what do we want to gather? What do we want to get? So we want to get a heart rate, blood pressure, and see if they're maintaining that mean arterial pressure to perfuse those vital organs. Are they in a life-sustaining rhythm? Or are they non-life-sustaining rhythm? And how can we correct that? Get an end title on there. See if you have a respiratory acidotic state leading to, potential metabolic acidotic state when, respiratory compensatory mechanisms start to fail. What's their temperature? What's their BGL? Sometimes with propranolol overdoses, you can get a pupil dilation, so check their pupils as well and see if there's on. Just help get a good clinical picture from head to toe what's going on with your patient, which leads us to their level of awareness. Can they tell you what happened, how much they took, what they took, if it was the prolonged release or the immediate release? Um, if they took anything with it, like I mentioned earlier, grapefruit, alcohol, anything to exacerbate the effectiveness of the medications they just took. And then, or maybe you can get into the other reasons as to why and all that other fun things or other reasons later on. But for now, it's just incident history that you really want to focus on. And then a 12 lead and an entitled CO2 again, just to get a better picture of the conduction of the heart as the QRS now starting to widen on you, and how you can treat that accordingly. And if they're in a life perfusing rhythm, if they've got bundle branch blocks, if they've got a history of an axis deviation, anything, if it's the heart weaker to begin with, depending on their level of health and physical fitness prior to this overdose, and if be mindful of how those underlying comorbidities can exacerbate the overdose in front of you. And then airway management, again, based off their level of awareness. Do they need any airway adjuncts right now? Are they protecting their own airway? Are they having passive regurgitation? Do you need to suction that airway? Are they in a pre-arrest state where you think now is a better time to take the airway versus waiting later on? Are they in a constant seizure? Are you going to start with an OPA and MPA and then, progressively work up either to the supraglottic airway or an endotracheal tube? And just managing that in a proactive setting instead of a reactive setting, and having that high index of suspicion. And then just doing a quick head to toe, just head to toe, to make sure that you did not miss anything. You want to look for injection sites, lacerations, maybe a note on the person if they are unconscious, explaining what they took, why, and just help get a better clinical picture as to what was going on. If there's any family members around, if they have a history of this, what medications were in the house they would have had access to, versus what they took on a regular basis if they were their medications or family members. Now that we've discussed the pathophys, pharmacology, clinical features, and physical exam, let's get into the treatments. We'll start with the hospital setting of treatments. So there's activated charcoal, as both of these drugs are mainly absorbed through the GI tract. So activated charcoal can be extremely efficient in the management of these overdoses. However, Coley and his team discovered that activated charcoal effectiveness drops off after 2 hours post ingestion of the verapamil and propranolol. So if you can get the activated charcoal into the patients within the first hour or two, the effectiveness is very good, and then after that starts to drop off. Vasopressors. So norepinephrine, epi-infusion, dobutamine. This is to increase the heart rate, increase systemic vascular resistance with that vasoconstriction, which will increase blood return to the heart and increase the force of contraction, which will really help those hemodynamic unstable patients. Normally, if you're having the epi infusion, you won't also do the pacing. But if you're going with the pacing route, then again, it's for those bradyarrhythmia patients that are hemodynamically unstable, just trying to get that cardiac output back up to maintain that mean arterial pressure. Also, there's intravenous calcium that they're going to be giving, just hoping to stimulate and get calcium extracellularly into the cell through L-type channels that aren't blocked. Then we have glucagon administration as well for the beta blocker overdoses. And then the insulin therapy. This is used in calcium channel blockers and beta blockers, because calcium channel blockers induce a hypoinsulinemia and insulin resistance. So by giving the insulin, we can increase the uptake of glucose by myocardial cells, which will improve the heart's force of contraction and peripheral vascular resistance. Then you have lipid emulsion therapy. Propranolol and verapamil are highly lipophilic drugs. So in theory, this lipid emulsion therapy acts as a lipid sink that draws the content of lipid-soluble medications from within cardiac tissue. And by doing so, this will improve cardiac conduction, contractility, and coronary artery perfusion. There's also ECMO available, which stands for extracorporeal membrane oxygenation. The ECMO machine is similar to a heart-lung bypass machine used in open heart surgery. It pumps and oxygenates the patient's blood outside the body, allowing the heart and lungs to rest. When you're connected to ECMO, basically blood flows through tubing to an artificial lung in the machine that adds oxygen, removes carbon dioxide, warms the blood, and then pumps it back into your body. Now we can talk about what we can do pre-hospitally. Pre-hospital. Sorry, dude. Well, we here in Ontario, I have atropine to respond to start with bradyarrhythmias to start. This probably won't be effective, but it's always good to start with least invasive, most invasive to try to get the patient to respond. Then we have dopamine, which is the vasopressor I carry, and 20 micrograms per kilogram per minute, just to try to get that increased cardiac output and increase systemic vascular resistance and increase return to the heart. We have crystalloids, which this isn't really a fluid loss problem, so I probably wouldn't give more than 2 liters here. 20 mils per kilo, max of 2 liters. This is simply just trying to get an increased return to the heart, get a bigger stretch, get Frank Sterling's law um, in play to help with the treatment of these hemodynamically unstable patients. Then with calcium gluconate, again, this is to increase the extracellular concentration of calcium and cause an influx through L-type channels that remain unblocked into the cell to help stabilize that membrane, as well as with sodium bicarb, changing that extracellular sodium levels to help stabilize that membrane. And then pacing again, if they're really unstable and you need to take over and get a life sustaining rate and rhythm, essentially, to maintain that cardiac output and mean arterial pressure being maintained and perfusing of vital organs. And then midazolam for post sedation or post transcutaneous pacing sedation, or if the patient's seizing, as propranolol can cross the blood brain barrier. You really want to start with good basic life support techniques, least invasive, and then moving into the more invasive advanced life support procedures as required. If you're going to be doing fluid challenges or giving drugs with short half lives, choose the appropriate size and location for your IV cannulation. An external jugular vein would be fantastic for a lot of these medications, or at least with an 18 gauge, especially if you're going to be doing fluid challenges and what have you. Now that we've talked about the treatments in hospital and that paramedics can give for these patients suffering from a propranolol and a verapamil overdose, we're going to talk about some transport decision making, things that'll tie into your transport decision. The things you want to consider: is the closest hospital the most appropriate hospital? What resources are available to them? Do they have ECMO, CT, labs? Is it a major center or is it a rural center? I know where I work, a lot of things shut down after 11 o'clock at night. You can't get any specialized CT, X ray, a lot of labs, depending on what time it is. A lot of things shut down at night in the rural hospital I work close to. As well as then you got to look at your patient. Are they stable enough to make, a 30-minute bypass, or are they unstable that they need to go to that rural hospital 5 minutes away to get some medications to help stabilize the cardiac membrane before they go to that higher level acuity center? Are you confident in your own skills to manage this patient should you attempt the bypass? Is your scope of practice sufficient to manage this patient if you're going to be doing a bypass, or should you be tiering a higher level of care if you're going to be trying the bypass, or if you got a prolonged scene time, extrication, or if you're going to be just a long transport time and you can relay with someone en route? If you're going to be doing the bypass and they're stable at the moment, just have a high index of suspicion that the patient's condition will most likely deteriorate en route, and just plan accordingly. Proactive is better than reactive in these cases. As for the transport itself, as per the Canadian Triage and Acuity Scale, this patient would be a CTAS 1, i.e., very sick, and paramedics should be transporting lights and sirens safely to expedite transport and treatment. I hope you all enjoyed the presentation. I look forward to talking with you soon. Here are the references I used for gathering information to put this presentation together. Thanks again, everyone, and talk to you soon.